first presentation will be from Spain, Dr. Turro, Roman Turro, on endoscopic approach to plicate tissue for treatment of primary obesity. Please.
Well, good morning to all the attendees. First of all, I want to thank for the opportunity to me to come here to do the presentation, and thank you for the organization to the invitation. What I'm going to talk about is about a procedure, endoscopic procedure, that it's post, and I'm going to give you a little bit a general point of view about what we are doing in Barcelona. So it works. Let me see how it works. Okay, next slide, please. Okay. And the next one does my disclosures, but we can go ahead because as long as you said that we are run out of time. So next slide, please. That's where I'm working. I'm working in a private clinic in Barcelona, which is probably one of the biggest private clinics in Spain. We have 20 surgical theaters, and we are doing over the year more than 20,000 surgical procedures. I'm working in the endoscopic department, and we've been doing working on the obesity treatment since 2000, and we've done more than 2,000 patients with the intragastric balloon. And now in the last 2 years, we started with the post. So next slide, please. This is the tools that we're using for the post, and I'm gonna introduce you a little bit each one. So if we go to the next one, next slide. Okay, this is the first device that we're using. That's called transport. That's a flexible device that we're using for putting in one of the channels. It has 4 channels. In one of the channels, we use a pediatric endoscope, and then in the other 3 ones, we are using the different tools that we have for the surgery. So if we go to the next slide, I'm going to show you a couple of them. On the left side of your screen, you see the G-Prox, which is a grasper where we can go through the needle. And then on the right side of the image, you see that grasper, the G-Prox open, and then the G-Lix, which is what we use to pull the tissue. I'm sorry because I have no pointer, so I cannot point you because it doesn't work. But it's that black thing. It's what we use for pulling the tissue. So if we go to the next slide, you here have an image about how it's supposed to get the tissue. As you can see, what we are doing is we're placing a suture, and we are getting the four walls of the stomach. So serosa, mucosa, submucosa, muscular, and serosa. Pointer is this one, no? Okay, here. Okay, perfect. Now I'm going to show you a video, and during the video I'm going to explain you a little bit what we are doing, because in this video you're going to see how is the procedure. I'm going to explain a little bit how is the procedure. I think that for the video you're going to have to play it from the back. Sorry, can you play the video? Because no, you have to go inside in the image. Because okay. So when we're starting placing the first shot. The first shot is supposed to be 2 centimeters from the GA junction. And what we are going to do is we're going to build 2 bridges. So here the first thing that we are doing is with the G-Lix, we pull on the tissue. And as long as we are pulling the tissue, we place the G-Prox open on the proper direction. We always want to go as much as perpendicular possible to the tissue according to get the maximum size of the bites. So when we are pulling, we do some aspiration for reducing the resistance of the tissue. And then when we have this, the distance of the grasper, it's 33 millimeters, which it means that the biggest bites we can do is 6 centimeters, 33 millimeters each side, which it means that it's going to be 6 centimeters. You saw that now we crossed the needle, and then it came out the first basket, then it came out the second basket. As you can see, it's like suture. It's not metallic device. It's just a suture. So then after placing the first one, we go 2 centimeters down, and then we go for the second bite. The idea, as we showed before on the starting images on the video, it's to build 2 lines of 2 breaches, and we're starting on the left side, and then we go, after finishing the left side, we start with the right side. The purpose of those bites here is to, on one side, reduce the fundus, and then also reduce the distension of the stomach. Now I'm going to show you how it looks like after placing some of the applications. We're usually going to place between 8 to 10 applications in fundus. Then that's the image, how you see, we can see the 2 breaches, and then that's when we're finishing down there. For avoiding bleeding, what we are doing is we are doing catheter spray with adrenaline 1 to 10,000, and we spray all the wall. So with that we avoid having that much bleeding. Usually that's what I was saying, that we are placing between 9 to 10 plicators, and then after that, after placing the ones in the fundus, we go down to the antrum. Well, not in the antrum, to distal body. That's the image before after. Then we go to the distal body, and down in the distal body we are placing between 3 to 4 plicators. The idea of these ones are to create some dysmotility and reduce the motility of the distal body. I'm going to show you one of the bites, and then when the bite is over, we can go to the next slide, because if not, it's going to take too long. Here the mechanism is exactly the same. We place the Gilix, and then we pull it, doing aspiration, and then we do the bite. As you can see, it's almost no bleeding. It's very safe. And if in any case this patient in the future needs to have any kind of surgery, it is possible to do any kind of surgery. We've been not in the patients that we've been treating, but at the beginning there were patients that after they needed to have a bypass or a lap band or anything, and there was no problem about doing that. So can we change the slide? Oh, I think we can do it like that. Okay, now I'm going to introduce you a little bit our results on the first patients that we've done since we started in 2011. This is till some weeks ago, we've done 105 cases. The average age is 42.4, and the mean BMI is 37.5. Actually, what we are going is to BMIs lower than 35. The ideal patients are between 30 to 40, but what we are seeing that we are having better results if we are going to patients with lower BMI. On those numbers, what you can see is that we had a little bit bigger BMIs, and that's why, because at the beginning we had some patients that they were candidates to have a bariatric surgery, but they refused to have the bariatric surgery. So we tried to see if they were having good results on this kind of patients. But my recommendation till now, would recommend obviously to go under 40, and if you want to have better results, under 35. And on the time, actually the time that it's taking to us, it's between 30 minutes to 40 minutes, but in the beginning we were using the first generation device, which it was taking a little bit longer, because we were using for cutting, instead of cutting with the G-Prox, we were cutting with scissors, and it was taking a little bit long. So when we started with this, it's again not working. Can you change slide, please? Okay, so this is the results of the first 45 patients. As you can see, we had a compliance of 75%, and the excess weight loss after 6 months was over 50 and 63% over 12 months. And 90% of the patients, they had a 25% excess weight loss after 12 months. The total body weight loss was over 16% at 6 months and 19.5 after 12 months. So next one, please. Okay, so then after we did the commercial with the commercial cases, we started to think about doing some kind of a study because we wanted to know what was behind this procedure. So we selected 18 patients and we designed this motivated study, which that included to study the satiety, the hormones, and the gastric emptying on this kind of patients. So I'm going to present today only the satiety because the other results we are still working on having the final results, but we're having a statistically significant, so even in hormones and even in gastric emptying, but I don't have here the results because it's still working. So I'm going to present you the satiety, which is very, very impressive, the results. So as you can see, the starting BMI was 36.3. We placed a mean of 14 anchors, 10 on the fundus, 4 in the antrum. We had no serious adverse complications. On the previous slide that I show you on the 105 cases that we have one patient that had an abscess on one of the plications, but it solved after 1 week of antibiotics, so it was okay. That was the major complication that we had. So next one, please. Okay, the satiety test, it consists in a drink of 15 centimeters of liquid isosource every 5 minutes until patient is recording the symptoms and the satiety. It was done before we did the procedure, 2 months after the procedure, and 6 months after the procedure. So we go to the next slide, please. And we saw that there was statistically difference between the volume and the time. Patients after 2 months and after 6 months done the procedure. All patients, they refer that they were feeling satiety before and they were feeling satiety with less food. So we were doing that with the isosource. So if we go to the next slide, please. Okay, and then that's the results of the weight loss on the patients that we did on this study. So you can see that the results are a little bit better than the results that we were having on the commercial. The mean of the excess weight loss after 9 months was 68%, and 89% of the patients lost over 25% of excess weight loss at 6 months. So it's kind of similar to what we were having on the commercial cases. 8 from 11 patients lost weight between the 6th and the 9th month, and 2 gained weight after between the 6th and 9th month. The last patient, it maintained the weight after between the 6th and the 9th month. So if we go to the next slide, please. Okay, so that's the conclusion. So what we've been seeing is that with POSE, we consider it a safe procedure because we have very high rates of satisfaction in our patients, and we didn't have any severe complications. But and it also appears to significantly impact the capacity and the time to satiety, and other psychological impacts and gastric emptying and hunger satiety patterns look like promising. But we know that we have to keep on working because we have less data. It's only 100 patients. Even in Spain, we've done in the last year and a half over 1,200 cases in the other places that they are doing also. And in the next months, we're going to start a multi-center study, which is going to take place in Austria, England, and Spain. So we expect that with this multi-center study, we're going to have more results and more data to show to the audience. So that's all. So thank you.
Thank you very much, Dr. Any question from the floor? Yes, please.
Yes, thank you very much for this nice presentation. I'm interested in knowing what will happen to the material in presence of acidity long term. Or do you give
Well, we haven't been checking You mean that the sutures, no? Okay, we've been checking patients done after 2 years, and mostly of the sutures, they are still in the position and looking with good appearance. I don't know in 5-10 years, because we haven't had any patient in 5-10 years, but the suture is the same one that you're using for any other kind of surgery, so probably it's going to stay there.
You haven't shown any barium or gastrografin study post-operative which show your suture accuracy. And second thing, you are against the physiological law, because if you approximate mucosa to mucosa, it will not
No, but
hold.
we're not approximately mucosa to mucosa. We're going serosa to serosa.
Yeah, but even the
That's
mucosa, it will not stick to mucosa. The only thing stick to stick is muscle to muscle. But even you approximate with suture, by time and mobility, this will break out. And all the procedure are using for hiatus hernia, almost all of them fail because they are doing the same procedure. It's fixing mucosa to mucosa, including the muscle. So if you don't break the mucosa, it will not heal.
No, but what we are doing approximately, the walls that we put in contact, it's serosa to serosa. We pull inside instead of outside, so it gets connected to serosa. We've been checking patients after 3-4 years, and it's still still the bites, and they are still in the same position. Obviously I cannot tell, as I answered before, that I don't know how it's going to look in 10 years' time. But what we do have now, it's the results on the beginning, because it's a new thing, so we cannot know what's going to happen in 10 years. But it looks like probably it's going to keep on.
One last quick question and quick answer.
Yes, thank you, Dr. Turro. The only one thing is, who's supposed to do this? The general surgeon or the gastroenterologist, number one. Number two, have you ever tried it with the leak, boss sleeve?
Okay, to the first question, I think that it depends on the country that you're working, because in Spain, for example, it's more common that the ones that are doing this procedure are the endoscopists, so the gastroenterologists. But in other countries, for example, in England, Austria, the ones that are actually in the multi-center study, it's going to be a mix between gastroenterologists plus plus surgeons. So it depends on the law on each country. I do think that it doesn't matter who is doing that, as long as it has the training, because it's only training. It's hands for doing this kind of procedure. And then for the second question, my answer is no.
Controlling the leak.
The boss leak. Leak from the sleeve gastrectomies or leak after bypass.
But we've been done controlling after like 2-3 years, but that's no. But I don't understand what you mean.
Complication of sleeve gastrectomies, like leaking after sleeve gastrectomy.
No, but we haven't seen in long-term complications yet. No, nothing.
Yeah. Thank you. Thank you. I think we have to.